Good morning, everybody. My name is Paul Devlin. I'm the Trust Chair at Lincolnshire Partnership NHS Foundation Trust. Welcome to our Board of Directors meeting. Delighted to have you either observing us live or indeed watching the recording on catch up. And as usual with our board meetings, we like to start with a story that's focused around patients and patient experience. It really helps us frame the way that we meet as a board and makes sure that we remember what we're here for in terms of actually looking at providing support for those who need our services. And today I'm delighted to be joined by Laura Copus, Rebecca O'Neans, we've got Sandra Beast and Sam Brown and Fionn Morden. Some of that whole team, I think, are with us today. Laura and Sam for sure, supported by Fionn, and going to be talking about the Children and Adolescent Mental Health Service CAMHS transition work. So I'm going to hand across to Laura and Sam and Fionn, please, to take us through your input. Over to you.
Good morning, Laura Copus here, the CAMHS Learning Disability Team Coordinator. Thank you for having me this morning and giving me the opportunity to talk to you about a piece of transition work that we've done. Next slide, please. Thank you. So I'd like to introduce you all to John. So I'm going to tell you a little bit about John before we start talking about the work that's being done with him. So John is an 18-year-old male. He has a diagnosis of a severe learning disability, autism, epilepsy, and a heart condition. John generally communicates through the use of PECs, signing, and some independent vocabulary. John has 24-hour one-to-one support and attends specialist independent education provider. He lives with his mum and his dad and his older brother. John has a specific interest in high-profile figures in the media who tend to have big personalities. He's particularly interested in Boris Johnson and Donald Trump. John and his family are very active and he enjoys swimming. He's a member of a tennis club and enjoys walking and jogging at weekends. John's been open to the CAMHS Learning Disability Team since 2014 for support around anxiety, and we transitioned him to adult learning disability services when he reached the age of 18. So if I just tell you a little bit about the reason for the CAMHS input, John really struggled with anxiety. This was displayed through agitation, so for example, pacing up and down, biting his own hand, and if not able to regulate emotions would shout and scream and hit out at others. John managed his anxiety with rigid and repetitive behaviours which were helpful for John but difficult for the family to support. For example, when initially accessing CAMHS, John needed 72 bedtime stories to be read to him in the same order and in the same way before he was able to sleep. Anxiety he also had around transition. So for example, John really enjoys every Saturday morning going to Asda for a bacon sandwich, and there was an occasion when Asda was flooded and John had to go elsewhere for his sandwich. This unexpected change in his routine was really distressing for John and caused him a great deal of anxiety, which required a great skill from parents to manage the situation safely. So that's just a bit of an overview of some of the anxieties John presented with. Next slide, please. So what work was completed by the CAMHS Learning Disability Team? So initially, when we became involved, it was clear that the family needed support to understand the complex needs of John and the need for support. The family were extremely resourceful, resilient and fully committed to their son, but were quite apprehensive about seeking support and understanding what that would mean. So through building a trusting relationship with the family and providing information of what support looked like, the family were able to receive support. We did work around positive behaviour support, also known, you'll hear it known as PBS. So PBS is a values-led approach which aims to improve the quality of a person's life and that of people around them. All behaviours have a meaning. Positive behaviour support aims to understand what behaviours that challenge tell us, so that the person's needs can be met in a better way. So direct work was completed with John to create a PBS plan, and this included the use of visuals, schedules, using sensory strategies and distraction techniques to prevent the use of physical or chemical restraint when John became over-aroused and overstimulated, which will sometimes lead to agitation and aggression. And also providing John opportunity to have his own space when needing to regulate his emotions, as well as an opportunity to be physically active, such as running and walking. There was also some psychiatry input, so work was done with the family to see the use of medication to gain a window of opportunity for the PBS work to be completed and be effective and make a positive change for John. There was liaison with other paediatric health services. So as we said in the beginning, John has some complex needs. So we needed to ensure that not only his mental health needs were met, but also his physical health needs too. So there was joint consultation completed between paediatrics and CAM psychiatry to ensure medication was prescribed safely by both services, and there was joint care planning in place. Liaison was also to prevent diagnostic overshadowing and to give John the best opportunity to self-regulate his mood and behaviours and be free of pain and discomfort. There was also work to be done with social care and occupational therapy to enable the family to access some much needed respite and to have adaptations to the home. Next slide, please. So what was the rationale for transition to adult learning disability services? So as John was nearing adulthood, it was recognised that there was still further work to be done, especially around the stamp agenda. So that's stopping the over-medication of children and young people with a learning disability, autism or both, supporting treatment and appropriate medication in paediatrics. So as I mentioned previously, medication was introduced to support the work that was done around PBS. And once that sort of been implemented and effective, John was settled and stable. Work had been done around to reduce his medication, and it was recognised there was still further work to do around this. There was work to do around physical health care. So within the transition from paediatric health services to adult health services, John had had experiences of restraints for the purpose of physical health care, and this had really increased his anxieties around accessing physical health care. And it was understood due to John's complex needs that he would regularly need physical healthcare reviews and the possibility of surgery in the future. And it was hoped that transition to adult learning disability services would support John to access the physical healthcare needed, as well as supporting services to understand how they could make reasonable adjustments for John so the use of restraint wasn't needed. And also multi-agency working needed to continue, ensuring all services involved were supported in understanding John's needs and that John continued to be supported to make decisions around his care wherever possible. Next slide, please. Thank you. So what were our opportunities and what were our challenges? So John had had a recent experience in transition around his education, and therefore had previous experience of processing information around transition and having those conversations and using his voice to make his views known. And as a result of this experience, John was presenting less anxious, happier, more trusting of others, and had an increase in confidence around those that were supporting him. John had grown and matured through his teenage years and was beginning to show signs of being more settled. COVID, in a way, provided us with an opportunity. So due to community resources being closed as a result of COVID, John had been supported to develop additional skills and strategies to manage uncertainty and disappointment. Additionally, as a result of COVID, the family had increased their walks and their activity outside, and therefore John became fitter, he became healthier, had more opportunity to spend time with family, and as a result, relationships were strengthened. And also there was good liaison with health and social care provision and other transitions happening for John. So he was being transitioned around sort of his heart, a specialist, neurology, social care, and these were working well, and the family felt really reassured by this. However, there were some challenges. So the CAMS learning disability team and the adult learning disability team are very different services, and we rarely transition young people outside of the need for psychiatry. Therefore, the clinician transitioning John wasn't entirely sure what could be offered for John and his family. The family had some anxieties. They were going to lose some current support and not know what future support looked like was an anxiety for them. There were some challenges around supporting John to understand the transition, what he would lose, what he would gain, and supporting new services to understand the intricacies of how John communicates and interacts. That was something that's gained through knowing John for a long time. And due to COVID, meetings were being arranged via virtual means. And although sometimes that can be a positive, actually sometimes it felt really hard not being in the room with all people involved discussing John's care. Next slide, please. Thank you. So what did we do? So we ensured that we had regular MDT meetings with family across services to plan for transition. So we got everyone round the virtual table to make sure that everyone knew what was happening. There were lots of discussions with the family and John about transition to adult LD. So information was provided to support these discussions about what adult LD services could offer. And these discussions happened about a year before we even thought about starting transition. So there was a long time to process and understand information. And this also allowed the family to have these discussions with John to support his understanding. And we ensured that we provided information in an accessible format to support John in understanding it. And we followed the transition pathway. So we prepared a transition summary with family to look at which took to adult LD to discuss and consider potential transition. Transition was accepted, and due to John's needs and also the restrictions placed by COVID, it felt that a clinic handover wouldn't be beneficial. So CAMHS LD and adult LD agreed to join John on one of his many walks with his family, albeit socially distanced, to introduce new staff from the service. That's where John's most happy and most comfortable. However, the day of the walk came and sadly there was torrential rain. Therefore, the transition meeting took place in the family's conservatory, which allowed John to come and go freely from the transition meeting and engage in a way that he wanted to and felt comfortable with. And I'm now going to hand over to Sam, who's going to tell you a little bit about what that meeting looked like.
Thank you, Laura. So yeah, on the day, as Laura said, we had hoped to go for you know, a good long walk, but I think actually meeting John and his family in the conservatory was really helpful, because the room that John spends most of his time in kind of adjoins the conservatory, so he was able to kind of come in, I think see me as a new face, new person, sort of check out, you know, look to his parents and probably Becky for a bit of reassurance, just say hello, and then he would leave for a few minutes, and I think each time he came back he stayed for a little bit longer. Sort of by the end of the meeting he was actually sort of saying hello and hello Sam, which was really good. And I think as also it John's kind of normal routine carried on through the appointment time, as you'd expect, I suppose. So I kind of got to almost observe live, if you like, some of the sort of routines and things, some of the things that really helped to kind of, I suppose, keep John at kind of like a baseline level of anxiety, I suppose. Some of the things were kind of, you know, at one point we had to stop talking so that he could listen to Beyonce, because he listens to a specific Beyonce song at a specific time. So yeah, I think the meeting just gave a real opportunity, I suppose, for the family to put a face to the name and to the service that John was transitioning to, but also for John to be able to kind of see who was going to be involved and things as well. And I think I suppose it helped for all of us to be together in the room as well, to like I say, just meet each other and I suppose address some of the anxieties from the family's perspective as well, about, you know, what support could be offered and things like that. Yeah, so I'll hand you back to Laura, I think.
Thanks, Sam. Thank you. Next slide, please. Thank you. So, positive outcome. We successfully transitioned onto adult learning disability services, and John is still receiving support from adult learning disability services and benefiting from the support. John's family are fully involved in John's care planning and are happy with the support being received. We've had a comment from John's mum, and she says, the new team, as in adult learning disability, are lovely, but we do miss you from CAMHS learning disability team. An action ladder is being produced to support John, and hopefully a lot of desensitisation to support hospital visits without the need to put John under anaesthetic. We feel very lucky that you got them on board, and it can only be to John's benefit, which I think is really lovely to hear. And good liaison and support between CAMHS LD and adult LD services. So throughout the transition period, ensured CAMHS felt reassured that adult LD had a good understanding of John's needs, and adult LD felt supported by CAMHS in providing accurate and up-to-date information in relation to John's need, so care planning could take place. Next slide, please. Okay, over to Sam.
Thank you. So I suppose we just wanted to, think about from our perspective as the adult LD service, what we found really helpful. And I think, as Laura has already outlined, kind of there was an existing PBS plan that school and family were using. So that kind of, I suppose, really laid the foundations and kind of gave us a really good base to kind of build off. I think particularly having regular NTT meetings with Becky and with family kind of gave us a really good overview of you know, the work that had already taken place, and also where John, his family, and I suppose Cam's LD could kind of see the work progressing. And I think that just gave everybody a really good sound kind of starting point. But I think the thing that we found most important was that it kind of gave us an opportunity to meet, I suppose, with Becky almost as the link person between kind of us as the adult LD service and John and his family, to kind of build those relationships quite early. And I think it really helped to kind of smooth the way almost in building, you know, a really good kind of relationship with John and his family. I think particularly, like I said, sort of, you know, when John was coming into the conservatory, and I suppose there were well, there's four, because his brother was there as well, four kind of really familiar faces, and then me as kind of a new person. But, you know, I suppose you could almost see him sort of working out how it all fitted in and things. So I think that was the main thing that we found really helpful and beneficial. Next slide, please. So in terms of kind of our ongoing work with John, as I think Laura's already outlined, there's quite a few kind of different areas of need for John, which has meant kind of lots of different members of the team becoming involved. And again, that's kind of been quite slowly introducing John and his family to new people with kind of a familiar face in there as well. So we've got the occupational therapist kind of looking at some of the sensory needs that John has, and kind of building on some of the existing work. The PBS practitioners, psychology and psychiatry, have been looking at kind of anxiety management, particularly around John accessing some future hospital appointments for his physical health, which I think has been quite a concern for John's family. But, you know, we're looking at how we can support them to kind of make that as positive an experience as possible. And I suppose that's where the acute liaison practitioners will also come in, kind of the link people within the hospital that help to make reasonable adjustments, or support the hospital to make reasonable adjustments. So I suppose we're taking a real sort of team approach to try and help meet those identified needs at the transition point. Next slide, please. So a bit more about that kind of ongoing work. So the desensitisation work around, the long-term goal will be around kind of going to the physical health appointments that he's sort of found very distressing in the past. We're currently working with family to introduce things like stories, but sort of social stories about people going to hospital and what sort of things to expect, to try and sort of help manage some of that anxiety. We've already had some successes in terms of desensitisation around his COVID jab, and also lateral flow tests for going back to school. Worked quite closely with one of the paid carers who essentially took a cotton bud and was sort of showing John on himself how what to expect, and then slowly but surely John sort of allowed that to kind of happen to himself, without sort of the need for any sort of coercion or anything like that. So it was very much a case of done on John's terms, and I think that was seen as a real achievement, because it's one of the things to help him go back to school safely. So now we're looking at sort of similar kind of desensitisation, looking at review appointments with kind of the cardiologist and other physical health appointments moving forward. So the DISTAT is a measure of distress and pain. We've completed that with John's parents and a paid carer. We're going to go through and have a look and sort of see how the people around John can kind of notice when he's in pain and then support him with that. So I think that's been a query sort of cause, if you like, of some of the anxiety and challenging behaviour that's been seen. Like I said, really the occupational therapist is involved for some of the sensory needs. As Laura was saying about STOMP, the psychiatrist is currently reviewing medication sort of in line with the STOMP agenda. The All About Me booklet is something that one of the PBS practitioners is developing with John and his family, and it's hoped that will be something that can support, because we're aware that school will sort of finish for John, I think, after this academic year, so there'll be a transition there, as well as sort of going to physical health appointments. So it's hoped that those around John will be able to kind of have something that they can grab, so that they can sort of see, you know, how best, I suppose, to support him, help to manage his anxiety. And then also an epilepsy care plan, again, to help sort of, I suppose, understand and spot sort of some of the seizure activity, and again, how best to support him. So that's a bit of the sort of short and long term plan for John. And I think I'm going to hand back over to Laura for the next slide.
Thank you. Next slide. This is the final slide. So we just wanted to sort of just think about our learning going forward for future transitions. What have we learned from this experience we can take forward? So we understand the need to consider transition early. So this allows for the planning of transitions to be bespoke and meet the needs of the person being transitioned. Commitment to STOMP stamp. So there's sign up from both CAMS LD and adult LD to the STOMP stamp agenda, which ensures any work started in childhood could be continued into adulthood. We felt the MDT approach to transitions was really important, and that the person's needs are viewed holistically. We really liked the period of joint working before, during and after transition to ensure there was good information sharing, good communication, offering reassurance to the patient and the family that agencies are working together, and it allows opportunity for endings to be managed well. And also service user and family being involved in decisions around transitions throughout. This is so important, keeps families informed, manages anxieties around change, and provides a joined up service, ensuring service users and carers' needs are met throughout the transition period and their voices are heard. So we are now currently in the process of transitioning another 17-year-old female who has complex mental and physical health needs to adult learning disability services, and we followed a similar process as Sir John. So that transition's been spoken about for some time. It's been started in good time. STOMP stamp principles are being taken into account. There's been a good period of joint working to ensure smooth transition, and the family now have access to resources available in adult LD that weren't available in CAMS LD. And I just wanted to sort of end on a comment from the mother of this 17-year-old. She said, "You don't know how much you have done for me. You think you are doing nothing much, but I can tell you that it's significant for my family." Next slide. Thank you. Thank you for listening to us.
That's great. Thank you, Laura. Thank you, Sam. And I'm just going to take a couple of comments from around the board table. But what a great example of how we can get our services right when we put patients, service users and families at the heart of our decisions. Anita, I'll bring you in first.
Thank you. The timing couldn't have been better for this. I actually spent yesterday for an hour and a half on the telephone to Paula McGowan. Now people might not know Paula, but Paula's talking next week at our nursing care conference, and she has pushed and pushed to share Oliver's story. Now Oliver was her teenage son that had learning disabilities and autism, and didn't have the most positive experience of psychiatric services, and was an avoidable death. I've just sat here and listened to this, and it is an absolute joy to listen to the work that you're doing. And massive thank you. And I'm actually going to take some of this presentation, because one of the questions that was asked yesterday by Paula, who's talking next Wednesday, was how are you going to take what I say next Wednesday and get it put into practice? Everything that I've heard this morning demonstrates that it's in practice. We just need to make sure that's across the rest of the trust. But massive thanks to all of you. That really was a pleasure to listen to.
Great, thanks for that, Anita. So I'm going to take Sharon and then Chris and then Sarah for a final comment before we move into the rest of our board business, if we can. Sharon, do you just want to introduce yourself and bring a comment in?
Thank you. I'm Sharon Robson. I'm non-exec director and chair the quality committee. Thank you both for today's patient story. It was really heartening to see that the physical healthcare agenda has been as important as the learning disabilities agenda for this individual. But I just wondered, as practitioners, how confident are you in your ability to look at physical healthcare? Because I know you worked with a lot of practitioners, the GP and others. I'm just mindful that Health Education England have just launched a competency framework for mental health and LD settings. And I wondered if you were aware of the framework or your level of confidence in understanding physical healthcare.
Laura, do you want to give us a response to that?
Of course.
Sorry to interrupt. Laura, do you want me to say anything on this? I do apologise.
Well, I'm happy to start, Fionn, and then you're happy if you would like to, if I miss anything. So I can only speak from a sort of a CAMHS learning disability perspective in terms of the physical healthcare. When I came into post, it was really apparent to me that the physical healthcare needs of children need addressing alongside their learning disability, autism and mental health needs. It's got to be a holistic approach. And so there's been a lot of joined up working alongside sort of paediatrics in doing joint reviews, making sure we're CC'd into each other's letters. Now, I can't say it always goes swimmingly all of the time, as multi-agency working doesn't, but we do work really, really hard to keep those lines of communication open. And more recently in the CAMHS learning disability team, we have accepted a trainee nurse associate to really focus on the physical needs of our young people to ensure we're meeting those needs. And if I'm honest, having somebody who comes from a perspective of physical healthcare first, it really has changed the dynamic of the team and the dynamic of the conversations that we're having as a team. We're supported quite closely by our consultant psychiatrist, Dr. Odmardi, and he has a very particular interest in physical healthcare. And I could give you a couple of examples recently where somebody has come to us for a mental health need, but after doing some basic checks and a referral to the GP, it's been really clear actually their presentation isn't due to a mental health need, it's due to a physical health need. And so it's something that's very high on agenda in all of the work that we do, and it starts right from the point of assessment.
Thanks, Laura. Fionn, did you just want to add anything around that framework briefly?
Just very quickly, that we have in the adult LD service, we have some roles. The specific roles is the physical health liaison nurses in each of our community hub teams, and we are looking at this competency framework with our physical healthcare lead. So in adult LD, I feel very confident that we really do have equality around both mental health, PBS, physical health are all linked for us, and that's how we work, and that's embedded into the adult LD service. And yes, we are aware of the HEE work that's been going on, and our going forward, our physical healthcare lead for learning disabilities will be involved in making sure that that's something that informs and helps us to do better.
Great, thank you. Quick comment, Chris, and then Sarah to wrap up so we can move on, please. Chris.
Morning, thank you, Chair. Morning, Chris Higgins, Director of Operations. Great story and just a great example of cross-team working, which I think is something that's it's been an issue for us in the past in different teams, but that example of working closer together to make that transition happen is obviously, it's really good to hear about. My question really is having done that, it sounds like a great story, but is there anything you would have done differently if you did it again? And I suppose supplement to that, is there anything that we can do as an organisation that might help make those processes easier for you as a team or for John as a service user?
Who'd like to take that one? Just get one of you to take it, Laura.
Yeah, I mean, I'm happy to do it. Now I'm speaking on behalf of Becky O'Neill, who can't be here today. She's on annual leave today. But I think the learning that we've taken from it, I think when we speak about what would we do differently, I think it's about making sure that it's bespoke for each patient. So we might do something different for each patient. So for example, with John, we were going to go on a walk and it was going to be a 5-mile walk. It wasn't just a round the block walk, but that's what John needed. But there might be another young person who needs something done differently. They might need to be in, a park or, in their family home. And I think it's about having that flexibility to meet that person's needs in that moment in terms of what they need. So our backup plan obviously was in the conservatory for John, and we did it socially distancing. We followed COVID guidelines, but we also ensured John could have access to things that regulates him, like having access to his Beyonce music and being able to listen to his song at a time that he chose. So I think for us, it's about looking at each individual case and offering a bespoke transition. And in terms of what could be offered to support us, I think just allowing that flexible working in us making the decision what's right for that patient and allow us that flexibility to do that. It's a great question. I'll probably think of other things that could be done after this after I leave, but that's the things from the top of my head. Thanks, Chris. Sure. I don't know if Fionn wants to add anything.
I won't take anything further, Fionn, and I'm sure Chris would welcome any further pieces of learning, Laura. So just before I come to Sarah, I know Ananta's referenced this being a very powerful and compelling narrative about implementing good practice in people with learning disabilities, and well done to the team. And Jane also added that there's much more we could be asking you, and I know I'm conscious of us needing to move on, but absolutely right, Jane, around those achievements that have been challenging in the past. So Sarah, do you also want to give a final comment?
Thank you. Morning, everybody. Sarah Connery, Acting Chief Executive. A massive thank you to Laura and Sam and Fionn for supporting in terms of sharing that story. And just to reiterate what other colleagues have said really about the timing of this, you know, the system is starting to come together as an integrated care system to really, you know, try and shift the dial on health inequalities. And for people with learning disabilities and autism, I mean, in terms of the life expectancy and the misdiagnosis, the figures are absolutely stark. But I think, you know, as we've heard today, with your relentless advocacy for this group of vulnerable people and the person-centred holistic care, I really do think that we can shift the dial on that for the people of Lincolnshire. And just to share a positive that. The annual physical health care checks for people with learning disabilities. I know we are one of the only systems in the country that has been able to exceed 80% in terms of those annual physical health care checks. And I often hear a big shout out for our physical health liaison nurses in achieving that position. So massive thank you. And just quickly, a farewell to Fionn and a thank you on behalf of the Trust, because she is off to pastures new at NHS England. So we forgive you, Fionn, and best of luck in the future.
Thank you.
Thank you.
Thank you very much.
Thanks very much. I absolutely echo that, Fionn, and thank you for all your contributions to the Trust and to those who have needed services. Great. So thanks, colleagues, for presenting, and we will now move on, if we can, to our routine agenda, please. So I think we've got a full house, so we don't have apologies for absence. I know one or two may need to dip out at points during the meeting, and if anybody does need to dip out, if you can just put a line in the chat bar so that can be properly recorded, I'd appreciate it. In terms of declarations of interest, our declarations register is attached. Can I ask if anybody's got any declarations of interest for today's public board meeting, please? If you could just indicate. Thank you. In which case, if we could go to the minutes of our last meeting, which was on the 25th of March, and can I ask if I can sign these as an accurate record, please? If you could give me an indication if I can sign these as a accurate record, please. That's great. Thank you very much, colleagues. And then if we could move to the schedule of actions and any follow-up. The schedule is there, and certainly looks to me like actions are closed. Jane, do you want to come in on this item?
Yes, thank you, Chair. Jane Marshall, Director of Strategy. I just wanted to inform the board that we'd had a question from a member of the public at our last meeting, and we've progressed that piece of work, and the person who asked the question has kindly agreed to be involved with us and her daughter, who is autistic. So that's progressing well, and I just wanted to give the board assurance that we had picked that up, followed that up, and are progressing it in line with the question. Thank you, Paul.
Great, thanks. It's good just to draw attention to the fact that we do that follow through, Jane. So appreciate that. Okay, if we go to 1.5, which is my remarks, I'm just going to say a couple of pieces, if I may, about this. First off, I'd like to just record my welcome to my successor, Kevin Lockyer, who will be taking over technically from Saturday as chair of LPFT. And Kevin is in attendance on for today's board, and you're very welcome, Kevin, and I reiterate again my congratulations to you. This last month, we are continuing to emerge from this pandemic, but I know that our staff and volunteers are continuing to work at a real pace to make sure that we can continue to provide the very best we can for all of those who need our services. And I put out a very big thank you to you all for that. I've obviously highlighted a few pieces of activity over the last month, and I think I will just reflect on the fact that this is my 53rd and final board meeting, public board meeting that I'm chairing at LPFT. It's been an absolute privilege to be with the Trust for the last 6 years, and I have been reflecting particularly over the last month or so, on some of the great journeys that we've had together in this trust, and I'm really proud to have been part of so much that has genuinely transformed the way that we provide care and services for the people of Lincolnshire, and I leave on a very proud note of all that the trust has done. Okay, I'm going to take the paper as read. Just pause briefly to see if anybody's got any comments on my paper there. In which case, let's move on, if we can, please, to item 2.1, which is the Learning from Deaths report. And Ananta, if I could invite you in, please.
Yes, thank you, Chair. Good morning. I'm Ananta Dave. I'm the Medical Director at Lincolnshire Partnership Foundation Trust. I'm assuming that the paper has been read. Happy to take any comments and questions. I want to draw your attention particularly to the reduction in the number of deaths recorded in March, which we assume is due to the reduction in the number of deaths associated with COVID. However, as has been mentioned in the report, because of the inability to get the accurate and detailed data about it, we are not able to confirm it, but it reflects national trends, and it is a positive picture in terms of COVID deaths. Also would like to draw your attention to the fact that in view of the good practice in the learning which is coming out of the structured judgment reviews which we carry out for those deaths which do not fit the serious incidents process or serious incident investigation process, or the LEADER, the learning from learning disability mortality review deaths process. We do structured judgment reviews, and that's highlighted good practice, and also fact that the ones that we've been doing so far have not highlighted major problems. So we are now going to focus on those patients who have died by who have dual diagnosis of substance misuse and mental illness, who do not fit the SI or the LEADER process. The last point is about the change in the manner in which, or the organization by which, the learning disability mortality reviews are going to be conducted. It was done by the University of Bristol, but as of May next month, it's going to change. The host is going to change, so we are awaiting the details, and we will let the board know and the organization know as soon as the details become available of how the LEADER deaths are going to be investigated. Happy to take any other comments and questions. Thank you.
Great, thank you, Ananta, and it's really good to see that focus on really seeking out the learning. Sharon, if I could start with you, please.
Thank you, Sharon Robson, non-exec. Morning, Ananta. I just wanted to check a couple of areas with you. One relates to the executive summary, which states that yourself and the Learning from Deaths lead review the cases to decide which ones are looked at in further depth. So my question around that is, how do you ensure that process isn't subjective and it's a robust process? And my second question, Ananta, is how do you test that learning is embedded down the line?
Yeah.
Thank you.
Yeah, thanks, Sharon. Good questions. So the decision about which process the deaths will be investigated by is done by a team, both as part of the patient safety team. And I think the important thing to highlight is that for any reason, if it was felt, for example, that the structured judgment review, if a decision was taken to investigate a death through an SJR, if it became apparent that some more details have been unearthed or highlighted which warrant a further detailed investigation, this does then get referred back to the patient safety team, and there's discussion within the divisions and at the mortality surveillance committee to then instigate a serious incident investigation. Similarly, when there are, if death does get investigated through the SJR process, and it was felt that it didn't meet the criteria for a serious incident investigation, so we follow the criteria which has been set out in the policy. We do have a desktop review as well. So there are ways in which there are checks and balances followed through following the national mortality tool for structured judgment reviews, the trust policy for investigation of deaths, review of those decisions at mortality surveillance committee if anybody raises concerns, and a reinvestigation through a more detailed process if it is warranted. So that's how we try and get the decisions right and make sure that the right process is being applied to each death. Regarding the embedding of learning, it is fair to say that it is an ongoing program. The appointment of divisional leads, patient safety or modern matrons working within divisions, for example, or the new patient safety lead role, and the learning from the National Patient Safety Agency, which talks about how it can be embedded more within organizations, are all things that have happened over the last couple of months to make this more robust. I think there is further work to be done, and over the rest of the year, we are planning, apart from actions being taken at divisional level and the quarterly patient safety newsletter, we are planning a series of trust events or days which will focus on learning, and the new revised suicide prevention training program, which has got 3 levels to it, also has a section of it which is about reflective practice incorporating learning from serious incidents. So it is expected that those will come into operation over the course of the year in terms of what capacity there is for COVID. But those are the ways in which we hope to make this process more robust and continue to do the work that's required to make sure that we are doing all we can to embed learning. Thank you.
Thanks, Ananta. Sharon, do you want to come back on any of that?
No, that's fine. Thank you, Ananta.
Great, thank you. Let's go to Hugh, please, if you could come in.
Thank you, Chair. Morning, Ananta. Hugh Howe, Senior Independent Non-Executive Director. Thanks for the report, Ananta. Note that we continue to work with bereaved families, which is an important part of the service. As a result of the reviews, do we have any plans in place to enhance that provision and support to families?
I mean, one of the things that we are actually going to be discussing at the next mortality surveillance committee meeting is the learning from the suicide bereavement report, which has now been circulated to both the members, and each of us are going to bring back our summary and what we can take from that report to embed within the organization. I think the first thing we are trying to do is, I mean, they have continued, these groups have continued in a virtual way because of the pandemic restrictions. We are trying to see whether we can introduce in a phased manner, in keeping with the infection prevention control guidelines, some face-to-face meetings to try and make sure that there is a more connected and a more person-centered way of supporting carers and families in grief. So that's the first step we are trying. And the second is to discuss the learning from the National Suicide Bereavement Survey, which captures the personal stories, really very powerful, moving stories from over 7,000 bereaved people, and to see what it is that we need to do as an organization. So that is, and I think that will inform us about what more we can do to support bereaved families. I think the thing that has already taken place as a result of learning from serious incidents is a big refresh of our carer strategy. So this was something which was repeatedly picked up about how we could work with carers in a different way. So the embedding of carer champions, refreshing of the carer strategy, involving them in our carer leads, in our review of protocols and processes has been really helpful. And I would like to thank Jane Marshall and her team, Donna Bradford, the carers lead, doing the work. So that is an example of how we have embedded learning from serious incidents and are supporting carers. But as I said, the other measures will also continue. Thank you.
Thanks, Ananta. Hugh, did you want to respond to any of that?
No, that's a very full response. Thank you, Ananta. Thank you very much.
Great. And I know that Jane's also picked up that support for bereaved people is part of the NICE guidelines, which underscores its importance. Andy, if I could come to you, please.
Thank you, Paul. Andy Spring, non-executive director. And thanks for the report, and delighted to hear that you're also going to do some work with staff in terms of training and stuff around these incidents. My question is probably quite a detailed one. It relates to the 3 patient safety investigators. I just wondered if those were proposed new posts, and if so, wonder what the rationale for that was, particularly given some of the difficulties we're having in recruiting frontline staff in some of the acute wards. So I just wonder if you could walk me through that, please.
Yes, I mean, I think the first reassurance I want to provide is that the money that is being used to recruit to the patient safety investigators is not at the cost of frontline staff or using money for frontline staff. And also at this point, if it is okay, I would like to bring in Anita Lewin, who would be able to answer that question in more detail and who has been involved in the appointment of the patient safety investigators. I'm happy to come back at the end of it. Thank you.
Let's hear from Anita. Let's try not to get too operational on it, but give us a board level response, please, Anita.
Not at all. As part of the patient safety strategy, it was clearly indicated that really we needed to move to a position around dedicated investigators. In terms of themes and trends, these investigators will work very closely or will be managed by Kathy, who has written this Learning from Deaths paper that we're looking at now. So in terms of kind of learning from themes and trends and progressing our investigation process, this is the way forward, and lots of work has taken place with operational services. But just to confirm, and we will come on to it later, this absolutely is not at the expense of any operational frontline staff. And actually we haven't taken, the staff haven't applied for this from operational frontline staff. Those posts have been filled, but we haven't taken anything away in terms of operational frontline staff.
Andy, do you want to just respond to that?
If I could, Paul, I don't want to second guess the executives in terms of decision making, but I tend to be a subscriber to prevention's better than cure. This seems to me to be investing public money in after the event rather than investing it to prevent the events. I don't want to second guess, so I'll kind of leave it to that, but my comment holds. Really, it's just being assured that we're doing the best for use of public money and the best for our patients by investing in 3 patient safety investigators versus investing more in the front line.
Let me bring Sarah in for a comment on that piece, Andy, because you've put a challenge into the execs there. So Sarah.
Thank you. Yeah, very good challenge, and it is something that we've pressure tested, as you'd expect, through the business case process. What we've been, well, I suppose to put it bluntly, we work in a mental health, learning disabilities and autism trust where incidents will happen, and we will always aim to focus on the prevention capacity. and learning. One issue that we've found is that actually investigating these as thoroughly and to a quality that we would like is taking up significant time of our quality leads within the triumvirates within each of the divisions. And it's felt that those members of staff need to be freed up in order to really focus on our continuous quality improvement work to potentially prevent the incidents in the first place. So there's something about making sure the capacity is sitting in the right place and that there is objectivity. So on that basis, it's not taken away from the front line. It's through a very robust business case process that we've decided that this capacity, in addition, is required in order to free up the right capacity at the right place for the prevention work, if that makes sense. It's an invest to save as much as anything. Thank you.
Thanks, Sarah. Andy, do you want to just respond to that?
No, thanks. I'd say I don't want to second guess that. They said to me they've had a robust discussion, robust business case. Sarah says it's an invest to save. So I need to take the executives at face value on that.
And I think what I'd suggest is that this is something that execs, you make sure you can bring back nice and transparently through committees, just so that the non-execs and the full unitary board can get a confirmation around that as this develops. Great. OK, well, thank you very much. Let's receive that paper. And if we could move on to 2.2, annual quality priorities. That's Anita, please.
So thank you. So as you know, as an organisation, we have to produce, we have mandated to set quality priorities. We're actually asked to set a minimum of 3. We haven't this year because of obviously COVID, worldwide pandemic. We haven't shared these as far and wide and has done as much public and stakeholder consultation as we would like. However, we have tried to kind of make up for that in the way that we've set these quality priorities. So each of the operational divisions said they wanted to set their own individual quality priority. So that is the way it's worked. I'm hoping colleagues on the board will see a close link from the quality priorities that have been set into some of the work that we've previously discussed. Again, the role of carers, patient service users in the care, and we're really beginning to see the triangulation of all of the work streams. We've just heard Ananta give a really articulated answer around the role of carers and service users in the mortality surveillance work, but also the progressive way. Those of us that are members of the quality committee heard a fantastic presentation last week on the carers work. So each of these quality priorities have linked closely with priorities within the division. Now, so one of the questions that I've been asked prior to this event is around the monitoring of these quality priorities and the best place for that monitoring to sit. What I would say is we are currently developing the framework for monitoring implementation of the quality strategy. And these quality priorities will also form part of that monitoring framework. We do have a monthly operations governance meeting, and the monitoring will go through there reported to PSEG. But I also propose that we have quality committees now quarterly, so potentially either quarterly or biannually we'll provide a report on these and the quality strategy through to quality committee. So I'm happy to take any questions on the quality priorities. They have been set by the operational divisions and they see these in conjunction with the trust quality strategy, and I suppose that the recommendation is around accepting these quality priorities, but I'm happy to take any questions on any of the priorities and indeed anything in the paper.
Thanks, Anita. Let's start with the chair of our quality committee, Sharon, please.
Thank you, Chair. Morning, Anita.
Morning.
It's not so much a question about the priorities that are outlined in the paper. It's just a question about the process, because we have a quality risk register, an organisational risk register, yeah. And on those there are some things, so I'll give examples, 2 examples. Physical healthcare is outlined there as a risk, and another one is the need to invest in quality improvement methodology and that big piece of work. And I was just wondering about whether there should be a marrying up between the risks, quality risks that the committee have identified and the priorities.
And I think that's a fair question, Sharon. Both of those things that you've highlighted are very clear goals with measurables in the quality strategy. Now, the clinical divisions made the choice that they wanted the quality strategy, and they were, sorry, I'm about to choke, forgive me. Sorry, they wanted the quality strategy, but these were extra parts that they wanted in. But those two issues that you've identified will be part of that reporting framework of the quality strategy implementation. So they won't, these aren't instead of, these are as well as the goals and targets in the quality strategy.
Okay, let Anita pause just to get her breath. And Sharon, do you want to come back on any of that?
No, I think that's fine. I just feel that given that we've got certain risks around quality, we need to make sure that they are our priorities.
Yeah. And that triangulation piece again, I think is an important piece of it. Jane, you want to come in?
Thank you, Paul. Jane Marshall, Director of Strategy. Sorry, thank you, Chair. Jane Marshall, Director of Strategy. I welcome these quality priorities, Anita, and I fully support the one at the top around involving people, including carers, in everything we do. The risk is if we don't, services suffer and the outcomes patients experience suffer. So whilst the Quality Committee did receive a really excellent report on the deep dive so far, just to give the board assurance that we won't be resting on our laurels, we'll be continuing to develop that carers agenda so that our carers become a key part of the story, and that's embedded across the organisation. And just to commend again the work of Donna Bradford and Di Rawston, who presented to the Quality Committee and that deep dive. Donna is our Trust Carers lead. Thank you.
Great, thanks very much for that, Jane. And I think we're then asked if we as a board will agree these recommended draft quality priorities, and the context I think we've tested out there around quality committee oversight and making sure that there is that triangulation with other priorities in the quality arena that come through things like the risk register. So could I ask colleagues to give me an indication if you're content to agree these quality priorities, please? Great. Thank you. Great. In which case, let's move on, if we can, please, to 3.1. Jane, if I can come to you for the staff wellbeing update, please.
Thank you, Chair. Jane Marshall, Director of Strategy. To introduce a paper to give the board assurance that we are continuing through our excellent staff wellbeing service to prioritise the needs of our staff from a health and wellbeing approach. I'll take the paper as read. It is a description of the services provided, but wanted to just make a couple of points overall about this. Mental health trusts are extremely well placed to be delivering this type of service, both for our own staff but also to the wider system, and the applicability of staff wellbeing across the system, particularly in the light of the COVID pandemic, is essential. And the Trust has been playing a major role in supporting system partners with their own people's health and wellbeing. So system applicability is key. But also, and possibly more importantly, this is a key piece of the jigsaw in terms of our recruitment strategy. And we'll hear later on in the integrated performance report some of the risks we are facing as an organisation to recruitment. So we are going to be celebrating even more the work of the excellent staff wellbeing service as part of our recruitment and retention strategy as well. Thank you, Chair. I'm happy to take any questions.
Great, thanks. Hugh, if we could come to you first, please.
Thanks, Chair. Hugh Howe, Senior Non-Executive Director and Chair of the People Committee. Morning, Jane. Thanks for the report. I know that we're doing some excellent work in this area. However, we have also started a new cycle of staff engagement and would hope that within the umbrella of well-being, we take the opportunity sensitively to address some of the thorny issues that we need to work through in terms of development, in terms of people management and moving forward. They're obviously tricky questions that we need to work through, and just want to be reassured that we are taking the opportunity to raise those points about harassment, bullying and so on.
Thank you, Hugh, and good morning to you as well. Yes, we are. So through the staff engagement cycle that is currently underway, my executive colleagues are supporting that process, and we are having very honest conversations to get under the skin of some of the data that we've had back from the staff survey, both positive and not so good, including a focus on bullying and harassment that our staff report they experience, absolutely taking that very seriously. So thank you for raising it, Hugh.
And Hugh, I'm sure you'll be keeping tabs on that through People Committee, which has been noted as a place where further engagement will be coming through at board level. Thank you.
Yeah, we will do. Thank you.
Andy, can I come to you, please?
Hi, Andy Spring, Non-Executive Director. Thanks, Jane, for the report, and I must commend the service on the good work they're doing to support staff and the system as a whole. It seems to me that this report's flagging to us that there are increased demands on the service. So I just wondered how the board will know when that service has met its, if you like, is at capacity, and we're running a risk of that service falling over as well, and how that will be flagged to the board.
Thank you, Andy. Jane Marshall, Director of Strategy, and Hugh Howe, our Non-Executive Director with responsibility for the chairing the People Committee, may also want to respond. But yes, and Hugh's put it in the meeting chat there, it is such an important area, this, and such a risk if we don't get it right, or if capacity fails, that we will be bringing very regular reports to the People Committee at every meeting to make sure we're on track. And in addition to that, Andy, we are about to commence a bit of a review and evaluation. So we're looking at the outcomes in even more detail that the service is achieving and how the capacity relates to that. And I think just to add, we are seeing a complexity in the types of work that team is doing. I highlight in the report here staff experiencing domestic abuse, for example, and some of those, the level of complexity and some of the support that we're needing to give to our staff is high. So we absolutely need to make sure that they're skilled up and have the capacity to deal with that complexity. So thank you for the question.
So, and Andy, I'm sure from a governance perspective, then knowing that any exception reporting will come through to the board from People Committee. Okay, and if we could go to Sarah, please.
Thank you. It ties in a lot of other people's comments. Thank you, Jane. And as Jane's just said, that she's commissioning a bit of a service evaluation of the service, because we have invested heavily in the staff wellbeing service, but in terms of the staff survey, we're not hitting best in class, so trying to get under the skin of that really. And as Hugh's referenced, the staff engagement cycles will be really important in building that evidence on how do we make this even better as you know, in order to support our hard-working staff, but also as a recruitment strategy as well. So thank you, Jane, and others for comments.
Great. Good. Well, I think that's one that we can be content that People Committee will keep a close eye on, and we'll be making sure that if there are items that need to be escalated to the board, that they will be. So let's move on to 4.1, the Organisational Risk Register. I'm hoping we'll take a short break after this item. So Anita, Organisational Risk Register, please.
Thank you. Sorry, I've got an alarm going off and I didn't want it to kind of pierce all of your ears. What I would like to say before I present this risk register, we know as a board we've had conversations potentially for the last 2 boards around the risk register and the way the risks are articulated, and actually if we've got it right, we know over the last 3 or 4 years we've done a full review. We're potentially ready for that next full review of how this is presented. So as an executive team, we had some dedicated time to this last Friday. Unfortunately, that wasn't in time to be reflected in this paper. But as we know, the papers come out the week before board. So we did have dedicated time last Friday, and we're all also booked in to have one-to-ones with the quality and safety team who kind of are the responsibility for the risk register and pulling it together. So I'm hopeful by May board, some of the conversations and some of the things that we've spoken about will be reflected in the risk register in May. But actually, in terms of this risk register, it is here for you. A couple of bits I just wanted to identify really was some of the risks have been closed since the last board meeting. You'll see risk 126, which is around the risk we had of dementia out of area patients. That has been closed. Chris Higgins, Director of Operations, has done a detailed piece of work with his operational staff to really combine all the risk associated with COVID and out of area. I think we can safely say at the moment, given our out of area figures, that's not a risk for us currently. It is something we are monitoring closely, but actually the work that's gone on there. So special thanks to Chris and the operational services for the work that they've done to tidy up those risks. Other than that, I'm happy to take questions. I'm happy to kind of pass over if there are any specific directors that want to talk about the risks on the risk register that relate particularly to them. Just one for me around the physical healthcare risks that we spoke about earlier. We have had commitment to and are starting to recruit into additional resource into the physical healthcare team. That has started. The training has been kind of restarted face to face with COVID measures in place, and I am optimistic that we will be reducing that level of risk at the end of May. But that work is taking place. But that's the key risk for me as the Director of Nursing I wanted to talk about. So happy to take any questions and comments.
Thanks, Anita. And if we go into any commentary, holding on to that framing that you gave at the start there, which does include, I know, board development time to do some review on this. Let me just open it up for any comments or questions, please. Anything anybody wants to pick out? Andy.
Andy Spring, non-exec director. Thank you, Paul. Thanks, Anita, and delighted the executive team are spending time looking at the risk register and articulation of risks. I think it will be really helpful to engage us in the process as well. I'm really conscious of the fact that actually, as part of that, I think we'll find that the executives are unconsciously managing a number of risks that probably aren't on our register. And I just need to flag that, try and make that a conscious thing that the things you are managing unconsciously or subconsciously actually are part of our risk register, and make that plea.
Good call, Andy. Anita, do you want to respond to that?
No, and I think they're fair comments, and I think you're absolutely right. I think sometimes we manage risks as part of what we do, and actually bringing those to our conscious will be really good. In terms of involving you in yes, we're going to pick up some board development time, but Andy, with your permission, I'm going to cut and paste some of the questions that you've asked previously for Mark and for Lucy, who are the two people from the quality and safety team that are doing the current review, and I'm actually going to ask them to have a meeting with you too, so that we can make sure ahead of the board development session that we are covering that work off.
Great,
thanks
Anita. Chris?
Yeah, thank you, Chair. Just to come back to Andy's point about some of the risks, and certainly take the point, and we'll pick that up in the work we do with the quality safety team. But just to also just make the point that there is further risk registers that are managed at a divisional and operational level and in some of our key departments. So there are a number of risks that are managed obviously by the services at the appropriate level, and what we see here are the top high risks that are scored most with the highest rating. So it's not that there aren't other risks. There's quite large risk registers that happen at other levels and managed at appropriate levels in the organisation.
Great, thanks, Chris. Helpful. So, colleagues, with the risk register, we've had some discussion about that, particularly around the context of that review work. We're asked to approve the risk register, notwithstanding any items that may come up in the confidential session. So, could you give me an indication if, in the context of that, having had that discussion, if you're content to approve the risk register, please? Great, thank you very much. So I'm going to suggest before we move into Sarah's Chief Executive report that we take a 5-minute comfort break if we can, colleagues, and then restart with the Chief Executive's report. So 5 minutes, please. Okay, I think we're ready to restart, please. So if we could go to item 5.1, please, Sarah, the Chief Executive's report.
Thank you, Chair. Morning, everyone. Sarah Connery, Acting Chief Executive here at the Trust. Just to start in terms of our regulatory position, so we maintain close contact with our Care Quality Commission relationship managers. In terms of, we have made the response in terms of the data requests that we've talked about previously as part of the transitional monitoring, but we're yet to receive a date for the actual interview, so we'll keep you posted on that. In terms of COVID-19, following the easing of restrictions as part of the government roadmap, we continue to respond accordingly. It's an interesting state of affairs where we're in the process now of sort of stepping down our weekly gold meetings, but being very mindful of what's taking place in the rest of the world, particularly the Indian subcontinent. So we're trying to do what we can to support staff who may have friends and family that they're trying to stay in touch with, given the very distressing situation over in India, and family do need to sort of make contact given the time difference potentially within work hours. So we're trying to be as flexible and supportive as we possibly can be. Just a bit of a shout out really to our very own Linda Stockwell, who's running the mass vaccination centre over in Boston. And for those of you who watched the government conference, the media last night, there was a personal shout out from Jonathan Van Tam to Linda and all of the relentless commitment that they give every day to ensure that the vaccination rollout is a success. As we've talked about previously, the exec team are engaging in a new cycle of staff engagement events, and it's really great, despite us not being able to be in the same room, but just to be able to virtually connect with our teams. And we're hearing some great feedback around our communication channels and overcoming some of those barriers to make sure that our staff can engage with the engagement, so to speak. So in terms of a regional position, in terms of our East Midlands Provider Collaborative, so the Child and Adolescent Mental Health and Eating Disorders Collaborative went live on the 1st of April. And we're looking now at what our governance looks like in terms of all of the collaboratives that have gone live. As you know, we lead the Veterans Collaborative for the Midlands. So we're looking at first meetings going in, and importantly, appointing an independent chair to make sure that all of the organisations are able to make sure that they're able to engage properly in those discussions, but that there's independence in terms of the chair role for that governance position. Seen as a bit of a pressure across the country in terms of child and adolescent beds. Colleagues are aware that we don't actually have Tier 4 beds in the county anymore, but it is a massive pressure in the rest of the country seemingly in terms of those Tier 4 beds. But certainly on a regional and national stage, Lincolnshire, particularly LPFT, is getting some, we're being pushed forward as case study on best practice in terms of beds not being the preferred option, obviously, for children and young people, and our model being put forward as a case study on best practice. So a massive shout out there for specialist services to Chris and the team for what they've done in terms of transforming children and young people's services. In terms of the integrated care system, really starting to ramp up the work around reducing health inequalities, and I think it's really pertinent given the conversation that we've had in terms of the patient story this morning about how we can make a difference to reduce those health inequalities. So the initial meetings have been met and priorities are being set. We've already talked about the out of area, currently at 0 for inappropriate acute and psychiatric intensive care. Not that we're going to rest on our laurels, so what we're looking at now is a focus on rehab out of area placements as well, to sort of apply some of the learning in terms of reducing out of area placements for rehab patients. So we've still got much to do. Joint dementia research, so just a plea for everybody really to sign up. We're aiming at, as part of Lincolnshire as a whole system, to get 300 people registered to take part in the dementia research studies. And as the Siren study around COVID infection rates and vaccination has shown, that we can make a difference in terms of that research being used to input in terms of national policy. So just to finish off, just want to be able to thank all of our staff, as I do every month, for their relentless commitment to excellent patient care. It's a real time for reflection as we look ahead to our Staff Excellence Awards. So we had over 300 nominations during 2020 and 21. A real challenge for the panel in terms of getting a shortlist together. But I think if you can read some of those stories, it's just so heartwarming and instills such pride in terms of those individual staff making such a difference to the lives, not only of the people that they serve, but their colleagues as well. In terms of we've got through this together through supporting each other. So I just want to say a massive thank you. Hopefully the report will show that we've got some real positive indicators of investment in Lincolnshire, as well as in Lincolnshire in mental health, learning disability and autism services, and we'll continue to push for more focus around those services as part of that health inequalities work. So I'm happy, I'll stop there, and I'm happy to take comments or questions. Thank you.
Thanks, Sarah. Just before I open it up, just want to really underscore the fact that we're being recognised by NHS England Improvement for tremendous work around both the children and adolescent mental health services, but also the out of area, and to have hit that 0 marker. I hope it's not breaching too much detail, Chris, but I know that in your interview when you were being appointed to your current post, the NHS England Improvement person on the panel was holding out an expectation that this target was going to be hit, and you've managed to, through your leadership and the hard work of your teams, to have managed to have reached that 0 point in the context, particularly of the pandemic, and absolutely bucking the trend of other providers across the Midlands is something that we really recognise as a great success. So I'll just pause to see if there's anybody wants to comment on anything else from Sarah's report. I think it's I think you've summarised things really well for us there, Sarah. So I'm not seeing any additional ones. So if we can stick with you, Sarah, and move to 5.2 system priorities, please.
Thank you. So this will be the last of one of these reports given as a senior leadership board. So that's all of the trusts and chair, all of the trust and CCG CEOs, accountable officers and chairs, chief executives, accountable officers and chairs meet on a monthly basis to talk through our agreed system priorities. Obviously, given 2021 was a bit of a peculiar year for performance management, we agreed that we still wanted to proceed with our key system priorities, given that part of them actually supports in the pandemic response, but to keep the reporting light. So we agreed a format that we felt was not overly bureaucratic on responsible officers, but gave a flavour of progress, importantly. So I will assume the paper is read, given what we've just talked about in terms of the out of area position. We had a conversation at our last system leaders board about any learning that we can take from that really positive position. So myself and Paul fed in about the strong leadership, clinical leadership, importantly as well, trust, making sure we're holding each other to account, ensuring people are clear on what their responsibilities are, and that shared holding across the system really in terms of these key targets. So hopefully there the report shows progress. We're in the process now of, as part of the planning round, talking about our priorities for 21 and 22, which we'll also in the process of agreeing what that reporting mechanism back into the boards will look like going forward. So I'll stop there and open up for comments and questions. Thank you.
Thanks, Sarah. And if we could just, if there are any comments that relate to the priorities that we have lead responsibility for, if we hold those for the next paper, but if there's any other comments around the common paper. I'm not seeing any. It's one for us, like the other boards in the system, to respond to. Andy, bring you in.
Sorry, I've probably mentioned this before, but because Sarah broadly brought the same report last time. To me, that there are some things that the broader system report misses that our report on our priorities gives us. The one on our, and I'll use it as the one on our priorities says to us, we're on track to deliver, and we've done the out of hours, so we are managing everything. In the broader system priorities report, it doesn't tell us whether they're on track or not on track, really. It doesn't give us the broader picture of the issue, and we don't really know whether they're in implementation phase or actually in planning phase. And given we've got two overarching major issues in the system, money and people, I've got no real sense as an organisation where the system is on those things. And I'm equally being expected to accept that the system's moved from a deficit 2 years ago of 95,000, underlying 99, to now 130 odd, with no explanation as to the movement between them. So I'm struggling with it as a non-executive director in terms of assurance, and I just want to really put that on record, that I'm struggling with the system stuff as a consequence of what I consider to be not good reporting of that transformation in a way that's helpful for assurance purposes.
Okay, and Andy, I think it's a good challenge, and part of it may be some of the context Sarah put in at the start around that lighter governance, but I think there's a really important piece there about feeding back in and testing this out within the system about whether there is a bit of a different way of reporting on some of this system activity, particularly highlighting those bits that for whatever reasons haven't been present in this format, but actually testing that out. Sarah, do you want to respond to that?
Yeah, please, thank you, and thank you, Andy, because I don't think you're alone in feeling that. I should imagine many of the non-executives from across the system, and indeed executives, are feeling the same way. And I think there's an interesting, we're at a bit of a transition point at the minute where we are firmly responsible for certain priorities in terms of delivery of the long-term plan for mental health, learning disabilities and autism service. But what does our assurance on the system priorities look like, and how far in detail do we want to go in that? So there's a spectrum. There's, you know, what we have at the quarterly system review meetings with NHS England Improvement, which is a 65 slide deck in terms of all of those priorities, versus the assurance. And I absolutely appreciate what you're saying about that reporting, because it is reporting light. I think it ties into our conversation, which we'll come on to later, around the consultation on the single system oversight framework as well, because we need to be clear on how we're going to get our assurance for that oversight framework, and it's not clear at the minute. So I think it's a really valid challenge, and I welcome it. I haven't got the answers, but I think if we can work it out together as a system, because I think you're not alone in how you're feeling about that lack of assurance.
I wonder, Sarah, if it's one that we can note and ask of you and Kevin to pick this up with the leadership board in the first instance, just as a way of, I think, then potentially having a bit of a conversation about how this report is landing with other boards as well, now that we've had it a few times over the last few months. Okay, Andy, is that helpful for you?
I was just typing in. Thanks, Sarah. Yes, it's helpful.
Great. Okay. And just see if there's any other comments in relation to this paper. I'm not seeing any further, and I'm sure that Kevin and Sarah will be able to follow that up with colleagues in the system. So if we could then move to the related paper on the trust system priorities, the ones that we've got lead for. And Jane, I think you're steering us through this one, please.
Yes, thank you, Chair. Jane Marshall, Director of Strategy and People. This report is the sister report to the previous one that our Acting Chief Exec, Sarah, presented, and confirms delivery in full for the system priorities that Lincolnshire Partnership NHS Foundation Trust signed up to a year ago or so. To note within this report, and I'll take it as read, full assurance on our delivery, and a link, I think, which Ananta Dave, our Medical Director, may want to come into, to Paul Devlin's Chair's report, where in that report, Paul highlights the importance of a recent publication from a commission on race and ethnic disparities, March 2021, and just to say the refresh of Ananta's work leading the system will include reference to that, and Ananta may well want to comment. And finally, from me, if I may, Chair, we have already started the working in collaboration with our system partners under direction from Sarah Connery as Chair of the Mental Health, Learning Disability Autism Board, for developing our mental health, learning disability, autism priorities for the coming 3 years, and actively creating the space for the system partners to come together to talk that through. We're at an early stage, but we're working in partnership with colleagues just to develop a collaborative approach across health and care and voluntary sector to define what we want to be working on, and that work is progressing well. It will be reported through to the executive team and then to the Mental Health LDA board, and then onward through the system processes, governance processes. Thank you, Chair.
Great, thanks very much, Jane. Ananta, I don't know if you want to come in on that specific point about that kind of trust and system-wide response to the report that Jane mentioned.
Yes, thank you, Chair, and thank you, Jane. Yes, Ananta Dave here, Medical Director. The system, the report by the Commission on Racial and Ethnic Disparities, published in March 2021, I think it would need to be taken with caution in the Lincolnshire system, because I think there is considerable data for us locally within the system to for us to need to firmly acknowledge the work that needs to be done to eliminate some systemic and structural inequalities. Now that's borne out by staff surveys, by the workforce race equality standard data, by reports from colleagues through informal proceedings, the bullying and harassment rates. So there are several indicators locally and stories, and we can't discount the power of personal narrative. So I think what I would say is that without being distracted by things which might seek to minimize or underplay the work that's required in the system, we focus on what knowledge is available locally, and a series of publications preceding this over the year, looking at the amplification of inequalities due to COVID, which give us the robust data and evidence, Public Health in England reports, Office of National Statistics reports, and the various things that have been done, like the setting up the Race and Health Observatory, which indicate the need to have a systemic perspective. So just to assure everyone that we are well aware of the challenge and the work needed to be done within the system, and will continue with that. Thank you.
Thanks, Ananta. Hugh, I think you've indicated that that particular report and how we respond to it is something that you'll be wanting to pick up through the People Committee. Andy, can I invite you in, please?
Thank you, Chair. And Spring again. Good report and a clear statement. We're on track, and I've said that before. I just wondered, in particular on our out of area placement work, whether we could say what lessons could the system learn from our work on that, and what can we learn as an organisation from it? Because I know there was some tremendous focus on it by Chris and the team. It'd just be helpful to have some reflection on that, I think.
Chris, do you want to give a response to that? And Sarah, maybe you would like to reply as well on the conversation that was had at the leadership board in relation to out of area. But let's start with Chris, please.
Yeah, specifically about out of area, but actually coincidentally I was contacted by a member of NHS England and Improvements team yesterday about putting together a toolkit for the do's and don'ts of reducing out of area placements. So I've been asked to contribute to that because they recognise I think we're probably just with the greatest improvement in the last 18 months nationally. So they've asked for our input into that, and so once we put that together, it's taking inputs from all the kind of successful trusts in the country, so we'll be able to share that round, and hopefully some of that learning will be able to transfer across to other areas of work as well.
Thanks. And Sarah, do you want to reflect some of that system-wide commentary on it?
Thank you, Chair. Yeah, just to add to Chris's point, because we did actually have Chris attend one of the previous system leaders groups when we saw in terms of the trajectory that we were going to, fingers crossed, hit the magic 0 figure. So just to add, I don't want to underestimate that Lincolnshire's capacity in terms of acute female inpatient was not sufficient, and it was a key part in this is a co-produced business case with our clinical commissioning group colleagues. So I just want to say sometimes investment is required, so we can do what we can, but it was one where we felt we were all pushing as provider and commissioner in the same direction, acknowledging that the capacity was not sufficient. I just don't want us to lose that point. And a massive thank you to the staff again at Ashley House, who have made sure that we could actually open the unit by transferring over on a temporary basis. So I just want to make sure that's acknowledged again. But in terms of that learning the lessons, we'll make sure that gets fed into the system leaders board as well when it's done. Thank you.
Thanks. And I'd just add as well, Andy, that some of the feedback from other partners in the system was about how well they felt involved with us on being part of the solution focused work. And I think that that's a real piece of learning for us, that if we can work really, really well across all of the partners in the system, we can actually really resolve some of these wicked problems that we've had challenges from over sometimes many years. Hugh, can I invite you in, please?
Thanks, Paul. Hugh Howe, Senior Non-Independent Executive Director and Chair of the People Committee. Just to say, Paul, that on the issue about the report on race and diversity, it is important that our staff know that we are going to reflect on this and make a response also with the system. And I think it's important as part of that staff engagement that we take the opportunity, if at all possible, in drawing some comments and feedback so that we get a representative view and it's not just the executive or the non-executive directors making a response.
Thanks, that's a really good suggestion, Hugh, and I'm sure it's one that Jane and colleagues will have heard there. I will say that I think that it's a report that in the way that it got presented publicly, there's been a bit of a risk of it sort of just kind of missing the point on some very key issues, and the importance for us as an organisation to really get underneath what the report says but also what it doesn't say. and make sure that we are responding well. And I'm personally really clear that systemic racism does exist within organisations, including the NHS, and we should be robustly continuing to challenge and really make our workplace and services a safe place for all of those who we want to be working with us and for us, but also who need our services. So I'm pleased that we're going to have that focused work to really get beneath that report and also the wider issues that it began to reference for us. Okay, and just to also say, in terms of this paper, the reference, Jane, that you'd put in around the system Black, Asian and minority ethnic workforce inequalities piece of work, just to really note that Ananta has been an absolute driver of this. And again, this paper, I think, reflects how we can influence within the local system. And the example, the detail beneath that one-liner there is of some great leadership and influencing from Ananta. So it's really welcome having this paper coming through. And I think being able to make sure that committees are able to give even more detailed scrutiny, as we've discussed, is valuable. Okay, let's move on if we can then to 6.1, the integrated performance report. And Mark, if I could invite you in to take us a steer through this. I know you'll be passing the baton across to colleagues, but if you can hold the steerage on this, please, Mark.
Excellent. So morning everyone, thanks Chair. So I'm Mark Platts, I'm the Acting Director of Finance and Information for the Trust. I present the report as read, and it is classed as a decision. So when we get to the end of the updates, we'll agree the work moving forward on this one. So I just want to start with a bit of an overarching comment, really. So we are continuing to refine the report. So you'll probably notice we are increasing the narrative within the report. So a little bit more context behind the statistical process control charts that are within the report. So within this section, I'm probably not going to duplicate a lot of the narrative that's now in there, but I do want to pick out a couple of three key metrics within the National Oversight and Trust Performance Metrics section. So the first ones that I'm going to mention, and I know we've talked about them briefly during the board session already this morning, are metrics 14 and 15 around the physical healthcare checks. So just wanted to assure the board around that the plans we did have in place around the additional training, the clinics that were being added and staff returning from shielding as part of the coronavirus is now starting to have a positive effect. So whilst we are still under the target within the report presented today, we are anticipating looking at April's data that we are moving in the right trajectory on that one. So there is a little bit of positive news on that one. So I just wanted to raise that. Another one to note really is metric 23 around the sickness. So this is another one that's continuing to reduce down. So we started the year reporting over 5% and we're now to the low 4%. So that's going in the right direction. So I think we're seeing some real positive impact of the COVID vaccinations and the wider impact on team workload and pressures. So hopefully that's looking good moving forward. And the final one I was just going to mention is metric 34, which is around the actual consultant-led referral to treatment time. So there is a focus on the service users within the Lincoln area at the minute because the predominant breaches of the target are Lincoln based, and there is a lot of work going on to sort that out. And there is some positive recruitment happening there. So hopefully moving forward, this will be a metric that again we'll start to see move back up as we move through as well. So happy to take any questions on the oversight and trust performance metrics. If there aren't any, if it's okay, I can hand over to Chris for the divisional updates. Thank you, Chair.
We'll just pause to see if there's anything from the overall. Philip, can I invite you in, please?
Yes, thank you, Chair. Philip Jacks, Non-Executive Director. Yeah, it's just on the 30-day unplanned readmission rates, Mark. I'm just looking at that. I noticed that we're still struggling with that a little bit, although I appreciate we're talking about small number variation there. And I know we obviously did the deep dive on this at the Sustainability Committee, but we still seem to be over that 10% target there. I noticed that each case is being analysed in some detail, but I just wondered whether we were managing to pick out any particular trends that we might need to be addressing.
Are you happy for Chris to take that, Mark?
Yeah, that's fine. Thanks, Chris.
Yeah, thank you, Chair. Thanks for the question, Philip. So you'll be aware, obviously, you mentioned the deep dive that we had at Sustainability Committee in November. We've got an update report coming to Sustainability Committee in May to set out some of the progress that we've made on that particular area. It's not progressed at the pace that we would have hoped or we originally set out. I think we're hoping for a 6-month improvement plan. As you see, we've had some inroads into it, but it's not actually had that sustainable improvement. Some of that's been around staffing and COVID related issues, which we'll explain to Sustainability Committee next month. But we've got some increased leadership on that, and we've got a revised plan that we intend to implement over the next few months, and we expect that to come back on track. In terms of your question about the themes and trends, what we are clear about now is that those patients that are representing they appear to have appropriate and robust discharge plans. What it seems to be is that in the community sometimes people have been admitted that we might have been able to alternatively keep at home. That admission avoidance piece seems to be the bit that we need to work on. So we are confident we're getting our inpatient pathways right. It's now making sure that the community teams and our partners in the system are robust enough to be able to keep people safe in the community.
Thanks. Philip, did you want to come back on that?
Yes. Thanks, Chris. That's really helpful. Obviously, we'll look at with some interest at the report when it comes back to Sustainability Committee, and that'll be very helpful, I should imagine. Thank you.
Great, Andy.
Thank you, Chairman. It's really a question around the 18-week consultant waits, and in particular the issue around Lincoln. Because this is one where we haven't been given, if you like, a time frame for when we expect it to improve by. So I just wondered if we could so what are we doing to minimise the overall waits for people, so that actually it's not just the Lincoln team that's feeling that pressure, that we're doing things to redeploy staff and therefore maximising our use of overall resources, and what date would we expect this to improve by?
Thanks, Andy. Ananta, I think, wanted to respond to that one.
Yes, thank you, Andy. And after me, if Chris wants to respond as well. It is an important issue, and what we've got is a short-term plan. So over the next few weeks, in fact, starting in May, we are having waiting list initiatives to actually deal with some of the earlier backlogs, so that the ones who've been waiting the longest are dealt with. So over the next 3 months, we hope to, through a combination of waiting list initiatives, we have a recruitment program which involves the appointment of something called the Developmental Associate Specialist post, which is development of internal talent to enable them to function independently at consultant level, but with supervision. And they will, in fact, the expressions of interest have gone out this week, and we will be appointing to those posts in May, and that will help in reducing providing continuity of care. We do have locum doctors, filling these posts, but it's about the continuity of care and ability to follow up. So that is happening. We've now got a full substantive appointment of clinical directors who are actually able to take the lead on medical recruitment and work through each of the vacant posts. So we've had a real push on that. I must say we are working very closely with the MDT team, because part of the pressures of the whole team is that sometimes there is a waiting list or there is an extra caseload and MDT staff, which means that patients can't be discharged from outpatient clinics and consultant caseloads effectively or early enough. So we are working very closely as an MDT. And the community transformation work, which has actually come into its own over the last few months, and where we've got extra investment, also means that there is a lot of work going on in the division to look at those patients who are on consultant outpatient lists and to see how they can be managed more effectively in primary care. combined with an appointment to a clinical academic post to the General Adult Division. So, and these are all recruitment processes which are currently ongoing as we speak. So a combination of these initiatives and substantive recruitment opportunities will improve the situation in Lincoln, with a specific reference to Lincoln. And so that's what I would like to say. I'm happy for Chris to come in if there is anything to add, Chris.
Not sure. Chris isn't giving us an indication there. Andy, there's also just to note that there is a target for reporting back in September on this. Do you want to just come back, Andy, before I go back to Mark?
Yeah, apologies, I've missed the kind of reporting back bit around September. I just thought, I think I was probably going, it's a long way away for something like that, particularly for those patients that have to wait that length of time. Obviously conscious of the impact of COVID. I just wondered if there was anything more that we could do as an organisation, really.
I think that will have been heard, Andy, and also in terms of that September reporting, obviously it brings in the August data, which means that hopefully the target has been hit a little earlier. Mark, do you just want to come back in on that one and then steer us in the next piece of this item, please?
Yeah, thank you, Chair. I mean, to be honest, it's already been picked up. I just wanted to draw the board's attention to that metrics tracking table on page 8. So this is a key thing that the business intelligence team are more actively monitoring now, and I've asked the team to make sure that this is really up to date for boards. So hopefully we'll be picking out the key metrics and give the right updates within that table. So it's just one to note moving forward. So if it's okay, I can hand over to Chris now for the divisional updates. Thank you.
Brilliant. Thank you, Mark. So just a few key highlights, just want to draw to your attention. So on page 12, which is the adult inpatient urgent care division metrics, just identifying there that, as Sarah mentioned in her update, is that Asheville is open now as our new female acute treatment ward, which is allowing us to bring back those patients that were previously admitted out of area, which is a really good news story for Lincolnshire, and really just recognising the flexibility and work of the staff at Ashley House who've allowed and enabled that to happen. Also, just for that division, just want to flag a piece of work that we're doing around Charlesworth Ward, one of our acute wards in Lincoln. Following feedback from staff and patients and a review of incidents, complaints, audits and inspections, we've initiated an intensive quality improvement piece of work on there, led by our head of operational service improvement, with support from the other corporate functions and services, to really try to work with the staff and team on there to look at how we can make some shifts in practice and processes to make things better, and also looking at that safe staffing element to make sure we've got the right staff to deliver patient needs. So should be a positive piece of work. Will take a while to embed. Turn us to the adult community and mental health division on page, well, the detail on page 17. It's just to flag the investments that we're having. So there's a lot of growth in mental health services over the last year on into this year. Most of that is focused around adult mental health care and the investments in the community mental health transformation that we've heard about. There's also investment expected in Steps to Change, which is our IAP service, and perinatal services. So there's a range of different investments coming in that will enhance the care and offer, and that also links back to the 18-week wait conversation we just had. Is that the ambition of that work is that over time we'll move to a 4-week wait as the maximum wait for people entering those services. So we're not there yet because it's at that early stage of investment and we're just starting the next wave of recruitment, but in time that's the ambition of that programme of work. Just to flag with the older people and frailty division, just a proactive piece of work around the review of suicide and self-harm incidents over the last 5 years, and there's been a thematic review of that that's led in other areas to some significant improvements in quality and patient safety. So a proactive approach to see if we can do something and find some new learning, and also just there the recognition around the new care lead that's starting division, and we know the impact of those posts have had elsewhere, so really positive. Just turning to page pages starting on page 22, which is the specialist services metrics, and the detail on page 24. You've got a couple of areas in children and young people services where we're not quite hitting the weights. Now, one of those is the looked after children weight, which we've had a deep dive report previously to the Finance Performance Committee in the past. small numbers make a big difference on percentages here. You say there's one patient that's made a difference, and there's some complications in terms of other partners' engagement in that process that affect our weight, and we're satisfied that we're doing the right thing for the children involved. With the CAMS routine weights, we know we've got a particular issue, and that's referenced in that table that Mark just talked about, and that is that we've had some vacancies, staff sickness and particularly long vacancies in Boston that's brought down the average waiting time. Those posts have been recruited to, and we expect it to be back on track in the next few months as those staff get on post. And then in Young Minds Matter, we've had 3 patients that missed the routine wait for that service, which is the wellbeing service. There's 3 patients, again, small numbers make a big difference, and with that, those 3 patients were offered appointments on time, but didn't attend, and so that slipped them outside the actual waiting time. It's been flagged by one of the non-executive directors, and I want to address the point that we've got, whilst there's a number of waits affecting CAMS services, they're coincidental rather than linked. That said, we do know that pressure on our crisis services for CAMS and our adult crisis services is mounting, or appears to be mounting, in the wake of COVID and the release of lockdown, and we're keeping an active watch on that to see what happens. But on this occasion and these metrics, they seem to be unrelated at this stage.
Thanks, Chris. Just pause to see if there are any questions or comments on this section. So I think the report itself actually makes it a lot easier this time, Mark, for us to be seeing actions that are being taken, which is good to see. So I'll come back to you, Mark, to steer us on then, please.
Excellent, thanks, Chair. So if it's okay, I'm just going to hand straight over to Jane to talk through the people section. Thank you.
Thank you, Mark. Jane Marshall, Director of Strategy and People. The people section of this report, I just wanted to draw the board's attention to three areas, but one which is of particular risk and concern to us that we're actively working together as an executive team to address. So to give assurance to the board that following comments about the length of time it would take for us to recover our mandatory training rates for our staff, we have addressed that concern that was raised at the last board of directors, and we're now on track to do the total refresh of mandatory training to a reasonable time scale, not the 2 years that was indicated in the last report that came to board. And there is focus on making sure that that is done as practically as soon as possible. The second area I'd like to highlight to the board on the people agenda is some of the variability in the managerial supervision and clinical supervision rates that you see within this report. We're about to commence a deep dive and project on that to really understand what the issue is behind that, whether it's recording of supervision or whether people aren't actually receiving their supervision. We suspect it might be the former, but we're just going to do a double check on that, and that will be fed through along with plans to address if there's any shortfall in supervision to the next people committee and then hence to board. The third area I'd like to flag with the board is highlighted in summary on pages 26 and 27 of this report, and is a significant risk that we are handling and have had for a while around recruitment, particularly registered nurse recruitment and retention, but also our medical staffing recruitment, which are highlighted on pages 26, 27 and 28. And if I may, Chair, just to take a couple of minutes to take the board through some of this narrative. So I'll take it as read, but I just 3 or 4 areas that I would like to highlight for the board's attention. The middle of page 26 there on registered nurse recruitment, we have had concerns about our level of percentage vacancy rate for registered nurses for a period of time, but we've recently done a piece of benchmarking work against our peer trusts, and you'll see from that table that LPF Lincolnshire Partnership rates at 15.9% as an overall vacancy rate, according to those benchmark data. There are various sources of data which are different due to the time at which they were analysed and presented. But we are obviously high relative to our peer trusts, and we are concerned about it. So we've commenced various initiatives to really understand what the problem is and, what more importantly, what we can do about it, taking an approach that says what can we do in the short term, the medium term and the longer term in terms of our workforce planning to recruit more people in. There is no immediate obvious solution to this problem. It is a problem that's shared nationally and locally within our system and wider. But we have on the bottom of page 26, we have started to look through the lens of this problem in a slightly different way, and some work that my colleague Chris Higgins did on with his teams, looking at not only the numbers of whole-time equivalent posts that are in the establishment, but the proportion of those posts that were actually substantively filled by members of staff in post. And at the top of page 7, you will see from our analysis the areas we are most concerned about that build on that analysis. And obviously this is a key issue for us, both in terms of quality, people and sustainability. What we're not saying at the top of that page is that necessarily the quality of care on those wards is poor. What we are saying is we're concerned about the level of dependency on short-term staffing measures to fill those gaps in staffing. So particularly use of additional existing staff doing additional hours, use of bank and agency to get the establishments up to the level that we need them to be. It's a particular issue for our adult inpatient wards, and those are shown there. So we've put in place a rapid recruitment team, an executive-led task force, which is a partnership between myself, Anita Lewin, Chris Higgins, our Director of Operations, and is ET sponsored. And on page 27, you can see some of the immediate steps that we've taken to look at those short-term, medium-term and longer-term solutions. It is a risk for us, but we're actively working very hard to look at the solutions that we can put in place to address the problem. And at the bottom of page 27 there on medical recruitment, you'll see how some of that, while we've still got a risk around the number of consultant psychiatrist posts that are not filled in the organisation, working in partnership with Ananta, having the right people resource to support her, we've been able to make some quite good progress on that, although there's more to do. So I'm really happy to take comments and questions from board members on that piece and to respond to any questions you might have. Thank you, Chair.
Thanks, Jane. We'll start with Hugh and then come to Sharon. Hugh first, please.
Thanks, Chair. Thank you, Jane. I think it's a very detailed narrative in terms of the challenges and reaction that we're taking. And I'd want to be supportive in saying that I think that we're doing as much as we can. What I'm pleased to hear also is that we're doing things quickly and trying out new ideas very, very quickly and see if those can make an impact. But I think the long-term issue will be about retaining staff, not just recruiting them, but retaining staff. And I think anything else that we can do to enhance the packages that we offered, and it's not always about finance, but a complete package will help us long term. But I'm supportive of the action that has been taken so far.
If I may respond, Chair, that's brilliant. Thank you, Hugh. And I think you're right. It's a combination of different attraction and retention mechanisms, opportunities that we need to be putting in place, and to think really quite creatively as well about new roles, different ways of working, how we link with partners elsewhere in the system, and how we galvanise the views of our people in sorting this problem out, because there are ideas out there that we need to capitalise on. And I look forward to bringing some of those through to the People Committee so we can confirm and challenge those opportunities. I also believe we need to make sure that we have systematic workforce planning for those longer term options, as well as the creative shorter term options that we can bring in quickly. And there is additional people capacity being brought into the trust to support us on both of those things. So thank you for that challenge.
Thanks, Jane. Sharon, if we could go to you, please. Sharon, are you on mute?
Paul. Yeah.
There you go. Yep, can hear you now, Sharon.
Thank you, Jane. That's a very thorough report. In terms of those areas where the pressures are highest, Charlesworth and Connolly, for example, how are the Oversight Group monitoring and measuring the impact on patients and staff in terms of harm?
So through that rapid recruitment team, we are focused on recruitment initiatives, and I know that there is work going on from the quality impacts that my colleague Chris Higgins would like to comment on as part of the short-term assessment of the impact of this risk. Thank you, Chris.
Yeah, thank you, Jane. Yeah, so just in terms of the where we've got any particular recruitment issues, obviously there's a staffing review that's carried out, and then there's shift fill rates that are monitored. So we do obviously actively monitor that daily in terms of shift fill rates, and that gets reported through the divisional management structures and both through to me and the operational governance committee, and then up to our executive team. So we've got a process to make sure that when shifts, and if there's any gaps in shifts, that we can see that happening. What the issue at the moment is not particularly around shift fill. As Jane's kind of suggested there, is we're reliant on bank, we're reliant on agency staff, and we try to block book bank and agency so that we've got continuity care for patients, but it's the sustainability of that. And when you're trying to embed quality improvement initiatives, obviously with such a transient workforce, it's really difficult to get the traction you need to make those improvements and changes. And where we'll see the impacts through board will be things like supervision, clinical management supervision, where you've got different workforce coming in. It's difficult to keep on top of those measures that we know really enhance quality. So there is a really particular piece that I referenced in my update for the inpatient division around Charlesworth ward, where we've had some feedback from patients and staff that we could make improvements, and so we're doing a really comprehensive quality improvement initiative around that particular ward, because that's where we've got our most, I suppose, concern. The other wards, they're okay and they're getting by. What I would say is that it's not a sustainable position, and so through the work that we've said through the rapid recruitment team is that we're going to put a formal review point in September, because we know that good will only go so far. We're expecting new recruits from the newly qualified nurses to come out by then, so we'll be able to see how many actually stay. And that's a really good checkpoint, really, to see the impact of what we're doing through the rapid recruitment work, how many new student nurses qualify and come to work for us at that stage, and make a decision at that point about longer term sustainability. But it feels like we've got stability now in terms of that bank and agency to keep everybody safe and well. We just need to see that some impact, I think, from the initiative that James spoken about just a moment ago.
Great, thanks. And Anita, could I ask you to come in just to pick up again on Sharon's points?
So Sharon raised the point as part of her question about how we monitor harm or incidents on those wards. Sharon, just for assurance to you, I met with the safeguarding team yesterday, but we know that safeguarding are regular visitors to Charlesworth Ward and Connolly Ward. They're part of their ward rounds. They meet regularly with the ward managers on those wards. But also I've asked that Mark Housel and the patient safety lead are involved in the work that Chris is talking about. So we are looking at incidents on a weekly basis. We are monitoring what is happening, and I'm in regular conversations with Chris just to make sure that, you know, Chris is absolutely right. We are using block booked bank and agency staff. So whilst the shifts look as if a lot are being covered by bank and agency staff, which potentially could bring inherent risks, they are the same staff that we are block booking. We haven't got different staff every shift, but while the staffing levels are as they are, we are monitoring that very closely.
Right. Thanks. Sharon, did you want to come back on any of that?
No, that's good. Thank you, Paul. Okay,
great. And just before I come to Sarah, just a reflection from myself. Jane, I think it's not for board level in terms of detail, but would be good just to ask that it gets considered as part of the analysis. Just having sort of people analysis of the movement of staff within our and between different services, particularly as we bring some new services in and transform others. Just getting that bit of a sense about, you know, what's making for attractive moves for people, whether that's about the style of working, whether that's relating to banding, all sorts of bits and pieces in there. And I'm sure that that's part and parcel of the data that your team are working on, but I just wanted to put that out there as well. So thanks for that. Sarah, can I come to you, and then I think we'll be able to go back to Mark for the final part of this report. So Sarah.
Thank you, Chair. So Andy's asked the question on what support that the non-executives can give on this, and I think there's something around challenge of our business intelligence. Statistical process control charts have really streamlined our reporting, but it's not the only show in town in terms of performance monitoring and highlighting risk. And I'm particularly mindful of how are we reporting in terms of safety issues, in terms of substantive staff, bank staff, agency staff, and people who might be working overtime. So I just think it's bear with us while we have a look and a refresh of our business intelligence reporting around ward staffing, I think, because I think we might have lost something along the journey in terms of moving to SPC reporting. And just one thing I didn't want to miss on the people section was a personal thank you to Ananta and also to Jazz Full, our Deputy Medical Director, for the work around the Developmental Associate Specialist role, which is really innovative. We think we might be the first trust who's actually kicked off that process. So I just wanted to say a massive thank you for thinking out of the box in terms of taking us forward in terms of our medical recruitment. Thank you.
Great. So Mark, if we can come back to you, please, for the final part of the integrated performance report.
Excellent, thank you, Chair. So yeah, I'll just close looking through the sustainability section, which is predominantly focused around the financial indicators on page 29. So I just wanted to open this report really just to kind of thank every member of the organisation, because the last 12 months with what's been going on in terms of COVID and the pressures on our services, and the fact that we've been funded nationally, so basically been told spend what we need to spend to combat the whole impact of COVID, and it will be funded. Actually, in reality, as an organisation, we've not spent a significant amount more than previous years, so we've really kept a really close control on that. So I just wanted to thank every member of the organisation for that, really, because it's enabled national funds to go to where they've been needed across the country. So just to kind of evidence that, we have actually broken even on a system reporting basis this year. So that's a really positive result on that, and there's a lot of hard work gone into that. Although we have reported a slight deficit of just over £400,000, that's driven by our annual accounting adjustment in terms of asset revaluation. So it falls below our regulation and how we're monitored on that. So a really positive result on that. I did just want to highlight to board the capital expenditure position, because although on the face of it, it does look like we've actually met our plan, this is quite literally a case of a £1 million swing one way and £1 million the other. So we have had to stop quite a few of our schemes during the year as a result of the impact of COVID, without being able to get builders on site and work to complete the schemes, really. So that's been a bit of a challenge on those. Those schemes are now back on track and being delivered as they can at the minute. But the main schemes that have brought us back in line with our plan globally is the investment in our dormitory accommodation. So as part of our being awarded £37 million to develop our dormitory schemes, we've actually spent just under £3 million this year on that. So whilst again that's slightly lower than we were hoping, it's a really good start to the scheme, a really positive investment. And linking to the dormitory schemes, I just wanted to flag the cash balance that we have at the end of the year as an organisation. That's significantly higher than we were planning, at just over £30 million. And again, that's been driven by the fact that nationally, NHS England Improvement have given us the funding for our dormitory schemes at the end of the year, ready for us to spend during the next 6 months of this year. So although it looks high, it is basically a prepayment on our capital expenditure. So happy to take any questions on the financial indicators, but that's the end of the report. Thank you, Chair.
Thank you, Mark. Any comments or questions on the finance piece? I think, Mark, you've clearly explained some of that piece around particularly the capital side of things, which I think is helpful just to underscore in terms of the reporting. Okay, in which case, colleagues, we're asked to agree any of the actions that have arisen from the report. We've had some quite detailed conversation appropriately with good challenge in there. So taking account of those discussions and challenges, can I invite you to indicate if you agree with those actions that arise from this, please? That's great. Thank you, colleagues. Let's move on then, if we can, to 7.1, consultation on a new NHS system oversight framework. Peter, over to you, please.
Thank you, Chair. It's Peter Howie, the Trust Secretary. The system oversight framework, there's currently NHS England Improvement are out to consultation on developing a new system oversight framework. First time it would be called a system oversight framework, because it's previously been an organisational oversight framework. This framework, the paper sets out where it's aiming to go. In terms of the domains and the areas that are looked at, they're not actually dramatically different from that we've been familiar with as the Foundation Trust. What is quite different is that there are now in effect two different sets of oversight framework. Firstly, for us as an organisation, and then secondly for us as a wider system. Now, I am aware that there's some information from a wider system perspective that isn't our information to share in public and may be best picked up by the Chief Executive in the part 2 today. But just to say that the system framework document also brings in what used to be the special measures means and links to the higher segment, the segment 4. We currently sit in segment 1. As a system, we would be in a system alongside LCHS, who sit in the segment 1, so that's the Community Trust, and United Lincolnshire Hospitals, who are under special measures and sit in a segment 4. So from the perspective of us considering how we might want to respond to this consultation, what I would urge is that people look very carefully at that implication for the difference between sort of minimal support in segment 1 and being part of a system in which a significant element is in segment 4, and that potentially could influence the way in which we would want to respond to the questions within the document. And I would suggest that our responses may be broader necessarily than just the direct questions that are being posed. So with that, Chair, I'll just leave that and we'll record any initial views now, and please note the intention to capture views afterwards to produce a final response, which I'm essentially asking that the board delegates the authority to send that final response to the Chief Executive.
Okay, thanks Peter. So let's just frame any comments now in the context of actually there's a fortnight to get more detailed responses back in, and there may also be some context that needs to be shared outside of the public board meeting because it relates to other parties' detail. So that may then inform any commentaries. Having said that, just open it up to see if anybody's got any initial or high-level responses to this paper. Andy, you come in.
Thank you, Paul. It's only a couple of comments. I don't know whether they'll be particularly helpful or not, so we'll frame it with that starter. The framework talks about it being an objective assessment, and there's one category they're using, which is leadership and capability. And I just wondered what objective measures they're going to use to assess leadership and capability. And the second bit is, how will NHS England improvement ensure consistency across the regions in terms of the interpretation of this framework and the use of it by their teams? Because I think it's really important for that consistency in order for the organisations to be able to learn from the best, so that those ones, if you like, are picked up. So I've no sense of where they are on this, and Sarah said she can have a go at that one.
So rather bravely, Sarah's going to have a go at trying to give you an answer on those ones, Andy. So I think some of those are perhaps questions that get formatted into replies to the consultation. But Sarah, do have a bite at it.
Yeah, thank you. Yeah, just completely agree. I think the consultation, if I may be contentious in the public arena, is to say that the questions are quite leading, and I think some of the detail will actually, that isn't available within the consultation response, will impact on how we might want to respond. So I agree. I think in terms of our response, it might be about raising questions that aren't answered as much as answering the questions, if that makes sense. But we have been in discussion with Region and the national team actually about what this might mean, particularly as a system, who would be in segment 4, and what this means for us as a segment 1, and what's the interplay between those two things. And I think that really plays in strongly and links into our earlier conversation about reporting. How are we getting assurance? Where does our job stop and everybody else's start? So some really interesting questions for us there. But the thrust of the assessments, as you say, there will be hard metrics, but there will also be linking in and triangulation with other softer metrics as well. So there will, or as a result of that, there will be some subjectivity, I think, involved in that. I think it's a really good challenge about consistent of approach, because it might actually rely on who is your regional director in terms of the answers that come out of that assessment. But in terms of our recovery support programme, the conversation is suggesting that it will be a memorandum of understanding that is jointly agreed between the region and the system. We don't quite know what that looks like, but it should be a conversation as opposed to an Excel spreadsheet that's got lots of figures on it in terms of once you hit this, then you're okay. Because I think the key thing that we want to be able to do is demonstrate sustainable improvement, not just we've hit a particular target in 1 month. So I don't know whether I actually answered your question, but I think it's maybe our approach to the response should be, let's collate our questions, because that actually influences how we might want to respond to these particular questions, if that makes sense.
I'll let me bring Peter in on the other part of your question, Andy, and then just come back to you briefly. Peter, did you want to pick up on the leadership metrics piece?
Yeah, I think Andy's question about leadership metrics is quite important. There are things that are going. There are hard metrics that have traditionally always been used, and they are things like the board turnover rate, and they are things like the staff survey and things like that, which are fed into the leadership metrics. But there's one really important thing that's faded away a bit recently, and that's the well-led self-assessments. And if there is a leadership framework which has the 10 questions within it, as a trust, I think we need to refresh our self-assessment and look where we are. And I think completing that self-assessment and being able to present our data, remember we're in segment 1, that means with minimum support, so they would be expecting us to do that ourselves and to present it to them rather than wait for them to measure our metrics. So I think that would be an important thing to bear in mind.
Great, thanks, Peter. So if I can come back to you, Andy, and then I just want to make an additional suggestion on some of this. Andy.
Thanks, Peter, and thanks, Sarah. I think what you've said is that if you like, formulating some questions as a response to the consultation is a positive thing that we can do as an organisation to help us understand the framework better and maybe help NHSE develop that framework in a way that's supportive. So yeah, it's helpful. Thank you, Sarah, and thank you, Peter.
Good. We have got a recommendation there and an ask that comments are provided to Peter by the 10th of May, and that we delegate the power to sign off the trust response to Sarah. Could I just add in a suggestion that if when those responses all come through, that Peter's also got a little bit of leeway, if possible and required, just to pull together a session with colleagues. If there are any bits where there are big disagreements, I think it may mean that you'd want to have a brief conversation. So I'm not saying you'd have to put that in, but I think perhaps Peter, yourself and Kevin and Sarah might want to know that you've just got the reflex there to just test out with execs and non-execs together, notwithstanding that the time frame of that may mean that it doesn't involve everybody in one bite. So are people okay with me adding that in? And in which case are you content to sign off that you'll feed in comments, delegate the power, and if required, come back together just to review anything that goes back through. It can be done via email. I'm not getting anybody waving no's at me there, so.
Paul, it may also be worth just acknowledging that there may be scope for a system response.
Absolutely.
And if there is scope for a system response, I think we would share with everybody electronically and just ensure that people could sign off to that as well.
Great. Thank you. I'm just peeling my way through those. Sarah, did you just want to comment? Yeah, Sarah.
Sorry, my unmute button's taken a little while. Yes, sorry, I should have mentioned earlier that actually the plan is that we would wish to, as we did with the ICS consultation, where all of the organisational responses are collated with a sort of a cover response on behalf of the system as well, to acknowledge where there are differences, not to try and sort of whitewash anything out, but to just acknowledge that we're cognizant of everybody's responses, and just to make sure that we are responding on as a system, even though we might have some differences of opinion. Thank you.
Great, thanks very much. So if we could move then to the forthcoming board programme, Peter, please.
Well, thank you, Chair. The forthcoming board programme is here for information. I think there's one point I would just like to make, and that is for the board development session in June and the one in August, we are proposing to find a physical building that we can have the board together. It will be a very large room with large spacing. All of the other meetings, as we've already planned, are scheduled up to October online. But given that the next board meeting will have 3 new members of the board, there is some team development to do, and there is quite a sort of full programme over the next 2 board development sessions. We felt it was going to be better to do that. In the event that the COVID risk changes, we can always cancel it and go back online, but we've made provision for that. Both of them are after the roadmap stage 4 of the government guidance.
Great, good clarification. Thank you, Peter. Peter, just to check, nothing that's emerged in our meeting today that's requiring consent agenda changes?
No, there's nothing under the self-certification.
Great.
I think I think the highest risk we discussed today was around the qualified nurse staffing vacancies in a few areas, but that currently doesn't warrant any certification risk.
Okay, thank you. I've had no A or Bs, so let's go to our review of today's meeting, if we can, please. Just that opportunity to reflect for ourselves on how the meeting has gone. I'll come back to you, Sarah. Do you want to do that before or after these? Should we reflect?
Reflect, yeah, thank you.
Okay, so just to reflect, colleagues, on how we've done, particularly in relation to the values, and towards the end of that, I'd also just like to invite Kevin just to be able to introduce himself. So can I just take any reflections, please, colleagues? I'll need to hear from somebody. Sarah.
Thank you. It's one of those where normally we'd have the posters around us, wouldn't we, if we were in the physical room looking at our values. But I've really felt the pride today. I don't know about other colleagues, but there's much. I mean, you know, we are still in a global pandemic, and there is much horror around the world, and still some challenges that we have indeed in our system. But I just want to acknowledge the good as well, and that there is much to celebrate. So thank you.
Thanks, Sarah. Anita, please.
I think, to be fair, it's very similar to Sarah, that opening story, and I said it at the time, but actually listening yesterday to a mum when it had gone so badly wrong, to hear from an LPFT perspective how incredibly right it had gone. It really was a powerful way to start today. So yeah, and again, it's just, you know, we've got our risks, we're open and transparent about our risks, but we celebrate our successes too, and I think we get that right. Thank you.
Thank you. Andy, please.
I think what I'd like to do is just reflect for us, the board, in terms of the work the executive team are doing. You know, despite the pandemic, despite the pressures, despite all of the things that are happening, the transformation that's happening, they're managing to deliver on many of our objectives, many of the things that we're doing. Everything isn't perfect and will never be perfect. It's kind of perfectly imperfect is great, but the papers were good papers, helpful to us in terms of understanding what's going on for the executive team and the organisation. So I'd just like to say thank you to the execs, really.
Thank you, Andy. And Jane, please.
Thank you, Chair. My reflection would be about the patient story too, which obviously was excellent, but also the contrast, Paul, between one of the first issues that you as a new chair had to deal with our learning disability inpatient service and the challenges that we had to quality, and then just how that's been transformed over the 6 years you've been with us. I thought it was really fitting to hear that, and part of your legacy, which I'm sure was planned, but brilliantly planned. So I just wanted to reflect that in, and Sarah's right, you know, the pride with which you can now view what the outcomes for patients and carers are from that burning platform we had all those years ago is immense. So I just wanted to reflect that back in, and also to say thank you to the board for the way you responded to that risk that we brought around our inpatient staffing and nurse recruitment, particularly, and medical recruitment. So just a big thank you. I think that discussion really helped do our thinking as an executive team.
Great, thank you very much, Jane. Kevin, let me give a final word to you to give any reflections, and then I'll go back to Sarah. Kevin, please bring yourself in.
I'm here, thank you, Paul. Look, I'm really privileged to have had the chance to sit in and observe your last board as chair. Paul, thank you very much for that opportunity. And it's a privilege to follow in your footsteps. So, and I'm looking forward to doing that. My reflections on what I've heard and seen over the last couple of hours, it's been a really balanced, appropriately challenging conversation. Really pleased to have heard the patient story at the beginning of the meeting, which I think powerfully framed the rest of the discussion. It was a really strong story, and I'm really glad to have the chance to hear it. And the other thing I'd observe is, a strong sense of values that have come through in all the conversations that I've sat in on this morning. So, look, I'm really grateful, and I'm excited about chairing my next meeting next month. So,
great.
Thanks, Paul.
Thanks very much, Kevin. Really appreciate that. Sarah, let's go back to you.
Can't remember what it was I was going to say. No, I'm only joking. Thank you, and I'm honoured to be given the job of your last public board with LPFT, Paul. To bid you a fond farewell. I think it's safe to say it's the end of an era, and I know you've been having lots of last ofs over the past month, but it would be remiss of us not to note the occasion. So just a massive thank you on behalf of the board. I've written down compassion and passion. I think this role has thrown many challenges at you, but you've always approached them with passion and compassion, and that has, fundamentally, I think, changed how it feels to be within this organisation. Personally, myself, we started at the same time. So I don't actually know what LPFT feels like without you, but a personal thank you from myself for your support with whatever hat I was particularly wearing at that time. In terms of those achievements, it goes without saying, it was a requires improvement trust. It's now a good trust with outstanding for well led. So don't underestimate your input in that progress. A thank you on behalf of the Lincolnshire population as well, because you've been an absolute keen advocate for mental health, learning disabilities and autism services, not just within Lincolnshire, but on a national stage as well, pushing LPFT and pushing for more investment. So a massive thank you for that. I just want to say we wish you all the best for the future in your endeavours. Don't forget about us. And in the same breath, I want to extend a warm welcome to Kevin. I hope we haven't scared you away with our board today, but just a massive thank you. And I know in part 2 we'll have a chance to share some more reflections, but I just wanted that to go on public record. Thank you.
Thanks, Sarah. Really do appreciate it. And I'm leaving an organisation. I'm leaving a load of colleagues. I'm also leaving a load of friends. So I really appreciate that. Okay, let's draw to a close this public board session. Thank you, everybody. And colleagues, can I just give me is 15 minutes long enough for us to take before we start our private board, please? Just give me a quick indication if 15 is long enough for folk. If we start at 5 to 20, okay, 12 o'clock. 12 o'clock restart. I'll be in generous mode then. So if we can restart at 12, please, on the other MS Teams link. Okay, goodbye, everybody. We'll see colleagues in a little while. Thanks very much.
Thank you.